My name is Marcia Hamilton. I teach clinical neuroscience on the Miami campus, and I have been teaching this for quite a long time. I have written some of your units, and hopefully you're not finding them boring. What I'm here to do is to talk to you about and talk with you about the first sections of the learning. And I'm going to take us through the first unit 1, unit 2, a little bit less, a little bit introduction to unit 3, and a little bit more into unit 4. And the way the course goes at this point, you would know that we're going to go through units 1 through 4, and then you'll be having your first exam. So do you mind telling me what campuses you're from so I have an understanding of what resources you have at the campus?
I'm in Dallas.
Dallas, okay. Nice to meet you. San Marcos, okay. Nice to meet you. I know you have Laura for your, yes, and I give my best to her. And in Dallas, I'm not sure of your faculty's name. Let's see, Dr. Lighthill, Chrissy Lighthill.
We have Dr. Fielder and Professor Boyd.
Okay, yes, I've met both of those teachers. So if you're in Dallas, you don't have access to brain specimens. I know that in San Marcos you do, as well as Austin and St. Augustine. So in my slides, I have some pictures of the brains, and hopefully, you'll find them instructive and, not upsetting. So does anyone have any specific questions about the course that you would like to talk to me about? Okay. Well, that being said, I'll just kind of go through and give you an overview of our learning so far, and into the future, so into the next few units. So most of the pictures that I use in this presentation are from your textbook, so it's familiar to you. And you'll be seeing this picture, I would say, I think about unit 5, but it's showing you different regions of the brain, and they're mapped to certain functions. And that's one of the things that we begin learning about as we learn about neuroscience. We know that each area of the brain is designated for a specific function. And when we study our neuroanatomy, it helps us align the learning of the anatomy with the function of the structure that is in that location. So to give you an overview, in your first unit, you learned a little bit about like an overview to neuroanatomy, then the neuroanatomy in chapter 2 of your text. You learned about neurologic exam and related to neurologic disorders, and that will be what will compose your lab practical exam at the end of the term, or shouldn't call it lab practical, I should call it a performance competency. And then a little bit about the physical and electrical properties of the nervous system, which some of that was learning about action potentials and how a signal is fired from the periphery or comes from the central nervous system out to the periphery. And then now, just in this past week, we've been learning about the importance of neuroimaging and how we use it as a tool, how it advances our health literacy as occupational therapists. We also learned somewhat about neuroplasticity, and then neuroembryology, neurodevelopment. And as you saw, hopefully you were able to see in the text, many of the disorders that are associated with neuroembryology or neurodevelopment we now have a better understanding that even say things such as autism, we know that there are areas of the brain that are atypical and causing the problems that are caused. So I think that's a very enlightening component of the course. What you'll be learning about next in your Unit 3 will be the autonomic nervous system and the peripheral region. So the autonomic nervous system is super interesting to learn about because you'll be learning about the sympathetic and the parasympathetic system, and really helps shed light on experiences, anxiety, and dealing with sympathetic nervous system reactions. And then finally, Unit 4, you'll be learning about the cerebral spinal fluid flow, blood supply to the brain, and also about the cerebrum. So I'm going to go ahead and go through the primary resources. That you have your textbook. So the Lundy-Ekman textbook is what we're referring to with respect to each of the chapters that are in the units. And you'll also learn that in like a section of approximately 6 different categories. And right now, as you can see, we really have already come up to the third part, where you learned about the development of the central nervous system and developmental disorders. And the vertical systems will be referring to how information travels from the periphery with respect to sensory systems up to the brain, how motor information comes down and goes to the different muscles, and then the function of the autonomic nervous system with communication that again runs in tracks, and that's why they call it vertical. We also learn about aspects of peripheral and the peripheral nervous system and the central nervous system, and tests, so neurologic tests. And the best thing, I think, one of the other great things about your learning is you're going to have a textbook that, as an occupational therapist, you'll likely use many times in practice when you're looking at dealing with anyone that has neurologic disorders. So our goal is, by the time you leave the course, you'll feel comfortable with understanding screening assessments and understanding pathology and structures of the brain and what's going on with that. So with respect to categorizing the learning, we can say that we go from the components of the nervous system, understanding the planes of the brain. So really that was Unit 1, how we study different structures in different planes, are elements of basic cellular and neurochemical organizations, such as neuromodulators, differences between white and gray matter, and then we'll define our primary sensory cortices and motor cortices. So the first thing we think about is at the lowest level, which would be the cellular level. And with respect to the cellular level, we know that the neuron is the cell of the nervous system. If you have your hand in your arm, what you can do is relate the dendrites to your fingers, the cell body as your palm, and the axon hillock, and then the axon as your arm. So think of it like that, and I think that helps you remember that. Remember, one of the important things to understand with respect to how information travels is it makes a big difference if there's myelin. So myelin will speed speed up the conduction of the information that's traveling in that axon. So excuse me, in the central nervous system, we have something called an oligodendrocyte, which is your what the myelin is. And then in the peripheral nervous system, it's called a Schwann cell. And the basic thing that does, it supports or it provides the insulation through the myelin. So think of it like the plastic outer covering of the cord, except it's better than that. So microglia. So their basic function of the microglia in the central nervous system will be providing help for the immune system. And then we'll have ependymal cells, which will create our cerebral spinal fluid. And one other thing I forgot to say is about the astrocyte. So that the astrocyte and the satellite cell are two cells that are very similar, the astrocyte being in the central nervous system, and we'll get to see a picture of that in our slide. So we know, and I'll go through just telling you what the structure is and what plane it is. So looking at this plane, we know this is an axial section of the cerebrum. So we have a right and left cerebral hemispheres. We can actually see in this case where we have the thalamus, and we can notice out on the side here, we can see some of the blood vessels that we'll be learning about. This inside of here is inside of the lateral ventricle is called the choroid plexus. And the choroid plexus is what makes the cerebral spinal fluid. They're most prevalent in the lateral ventricles. And then notice on every section that we can see the outer gray section, that's called the cerebral cortex. The gray shell is the cerebral cortex. The white that's underneath it, these are tracts. So these are bringing information to or from the specific area of the brain where it is. So, or what the function is. This will be, we have heads of the thalamus. I think I mentioned that. And it's very interesting. Remember, you would be learning about an overview of the Brodmann's areas, and this book doesn't refer to it as much, but it does have sections where you can see what the cortices do in different regions. So remember, we'll have the central sulcus, we'll have in front of that toward the frontal region or more rostral, we'll have the primary motor cortex, and we'll have the central sulcus, and then we'll have the primary somatosensory cortex. So all information that is for motor control, that's on the left side of the primary motor cortex is going to the right side of the body. And then what is on the left side what's on the left side will go to the right, what's on the right will go to the left. So we'll learn a little bit more about that. But in the central nervous system, the gray matter, called neuron cell bodies, they will be nuclei, except on the cerebral cortex, and then it'll be referred to as a cortex. So that's the outer shell. So here are more pieces or more sections of the brain. This is the inferior section of the brain. When we look at that, we can see the temporal lobes. We can see a lot, honestly. So I'm going to start up at the top, and I'm going to tell you that these will be the underside of the frontal lobes. There are sections that are missing here, but one of the best things about it is being able to really see, like this is an olfactory bulb that would be up in here. There's two of them. If we make our way down, we're going to see the optic chiasm. We're going to see the internal carotid artery. The internal carotid artery, if you haven't learned about the circle of Willis yet, you're going to be learning about that. And that is what provides the anterior blood supply to the brain. So from the blood supply to the brain is divided into anterior and posterior sides. The anterior blood supply to the brain is coming off the aorta, goes to the common carotid artery, and then that splits to internal and external carotid artery. And this, in fact, my arrow, is crazy to think about how big that blood vessel is. And that's pumping blood and maintaining blood inside of the arterial wall. And this will provide and nourish for the brain itself. So the cortical blood vessels, you'll be learning about them in Unit 4, are what will be the primary providers for our cerebrum. So here you can see, let's see, here's internal carotid artery, and then we'll make our way down and we'll go to what would be the basilar artery. So it's stopped right there. But this is, we can see the brainstem very easily. This is the pons. Remember that motor information will be running down through the pons. We have sensory information that will come up and through the pons and up through the medulla, the pons, and then the midbrain, and then go to the first sensory. We'll go to the primary motor cortex on the other side of the brain, and it will be coming down from the primary motor cortex on the opposite side of the brain to the muscles where it feeds. So this is the pyramids. So remember, this is down here, the pyramids will cross. So this is the long tracts of motor control. This is will be coming down here. So this is your primary motor control. And here's the cerebellum. So you can see the cerebellum on that side. We don't see it on this side. Let's go on over to this section, and here we're going to see the inferior surface of the brain, and we can see the outer layer. It looks like it's a film right here. This is part of the meninges. The meninges there's 3 of them, or 3 main layers. It would be the dura mater, which is the tough outside layer, and then coming in we have arachnoid and pia layer. And in the case when there is no more life, the arachnoid and the pia layer are sealed together. But during life, the arachnoid layer, what is under that, will be our cerebral spinal fluid and all of our cortical blood vessels. So very important how they're cushioned, and the meninges, remember, they'll provide support, they'll provide protection, it provides honestly nutrition. So the meninges are very important. So let's see, you can see the meninges, and now we can go to the optic chiasm. So here's where the pituitary gland will be, and you'll learn about that in your course. And this essentially is the circle of Willis with the posterior communicating artery coming off of it. And then here we have another blood vessel, our posterior cerebral artery, that will provide for our occipital lobe. And then here's our basilar artery. And all along the side of the brainstem. So the brainstem consists of the medulla, the pons, and the midbrain. You'll see cranial nerves. So there are many cranial nerves. In fact, if I go back over to this one, well, let's go to this one. This is a trigeminal nerve. So we remember cranial nerve number 5. And then we'll have a lot of cranial nerves here, like 6. And we would have 2 of them, 6, 7, 8. And then we would make our way down to glossopharyngeal, vagus nerve, and so on and so forth as we come down. What's important about this is you can really get an extent of how big the cerebral cortex, the cerebrums are. So remember, the cerebrum has 2 hemispheres, a right hemisphere and a left hemisphere. So that's what this is here. And then as we come further down, we're going to go to the cerebellum. And then this is the spinal cord, and this is the anterior side of the spinal cord. And then this one is a mid-sagittal section. And once again, you can see the gray outer cortex, and then the white matter here. We have essentially, when we look at this, we know that this would be the left hemisphere, and we know this would be the frontal lobe. And this will come back to about here, where we'll have our primary motor cortex, and then the primary somatosensory cortex. And then we'll come all the way back with the parietal lobe to the occipital lobe. And then here we'll have the division for vision, the areas of vision. And then you can see the cerebellum. And I think what's interesting about this view is you're going to see the big lateral ventricle. And this is underneath, essentially, the corpus callosum. The corpus callosum is the biggest white matter fiber tracts that connect information, that connect the right and left sides, and will be for sharing information from both sides. This is going to be the head of the thalamus. So this will be the left thalamus. And then we'll have the midbrain, and here's the pons, and here's the medulla. And this would be the left thalamus, and then 1/2 of the midbrain, 1/2 of the pons, and 1/2 of the medulla. So does anybody have any questions about this? Are you doing okay with this information?
Yes.
Yes? Am I being boring? Is anybody getting bored?
No.
No, you're okay. Good, thank you. All right, so let's go and look at a few more different sections. So if we look at this section, this will be a coronal section. So if there was like, imagine like a headband type section. So what I can see here, what I think this is a very funny section. I see a lot of like it looks like faces here. And these I'll explain to you as soon as I get my arrow back. Here's the lateral ventricles. Here's the corpus callosum. So this is connecting the two hemispheres. This is missing a piece where I'm going to say it's probably between the frontal and the parietal region. So this is where that is, because we can see the corpus callosum. And then here we're going to see what's called the internal capsule. And this is all white matter. So white matter tracks. And this is communicating. So remember, we're going to have motor information coming down from here and down from here, and we'll have sensory information that's going to come up. So that's why it looks like this. So corona radiata is called like the crown of white. And then here you can still see the gray matter on the outside. And what else do I want to show you? Here's going to be, here is the hippocampus. So there's two of them. I have a very good joke about the hippocampus. Does anyone want to hear it? Yes?
Yes.
Okay, good. We need a good laugh right now. So what did the brain say to the hippocampus during his speech? Thank you for the memories. Thank you for the memories. The hippocampus provides our memories. They're so now do you get the joke? The brain is getting an award. He has a speech and he says, I want to thank the hippocampus for my memories. So that'll help you remember what the hippocampus does, part of the limbic system. So here will be the midbrain. So coming up, it has these columns, they call them peduncles. And here's the pons. And then coming down here, this would be the pyramids, and then the medulla. So, and the cerebellum. I think the cerebellum is interesting. You know, any time that there are folds, it's going to increase the surface matter. Now, this is an axial section, so horizontal, like this. If you had a watermelon and you cut it like across like that, that would be how this is. So what do we see up here? This is crazy because we looked at lateral ventricle over here, but now in this section, it's almost like if you, I don't know if you ever made like snowflakes in paper when you were little, like you cut different parts of it once it's folded, but it's like that with the ventricles when you look at this section, because you can see the frontal. This is the frontal pole of the two lateral ventricles, and this would be the posterior pole. And so this would be backed by the occipital lobe. And here you can see the white tracks that come back here. This is all for vision. And this is going to the occipital region. So it's hard to believe that you see up in the frontal region and the information will go all the way. We saw the optic chiasm, and then it will go all the way to the thalamus and then come all the way back organized. Right to the occipital region is where the primary visual cortex is. The blood vessels you're seeing here, in this, I'm going to say that this would be the internal carotid artery. This is going to be the third ventricle. So the third ventricle would be up in here. The third ventricle is actually between the two thalami. So it's a much smaller area. And from the third ventricle, the CSF goes, cerebral spinal fluid goes to the fourth ventricle. And then let's go over here. This is more of the stuff that makes cerebral spinal fluid, choroid plexus. And then this is the mid-sagittal section. So hopefully you feel really comfortable with knowing your planes going from coronal to axial to sagittal. Remember, if you're trying to figure out if something is right or left, look for where the cerebellum is. So this to me tells me this is left. The fourth ventricle will be here. Here's pons, so pons is facing forward. This will be the frontal lobe. This is the groove between the parietal and occipital lobe. And then here is the division of the primary visual cortex. And you'll have the primary motor cortex here, primary somatosensory cortex will be here, and then you'll come back all the way, and that will be the end of the parietal lobe. Okay? Good. Okay, now what about this? Why do you have to know this? So we're teaching you about neuroimaging because, number one, it really helps us understand the anatomy and get a concept of pathology as well as normal anatomy. And it also helps us understand from the standpoint of what somebody may be going through. So I can use the example, I would say I can use the example of my own mom. She has normal pressure hydrocephalus, so she's lost a lot of motor control. She has frontal lobe dementia. So she got to a point where her blood pressure was very unstable. Her balance was very bad. And we went to I took her to the emergency room and CT scan. And I looked at it and I said, it looks to me like my mom has hydrocephalus. And the doctor said to me, I thought you were an occupational therapist. And I was just like, wow. That wasn't very nice. So yes, I said, yes, I am. And occupational therapists learn about the neuroanatomy, and we learn about how it affects function. And the more we understand the pathology associated, the better we're able to help our patients, especially with neurodegenerative disorders. So understanding what the pathology is and moving forward from there. So I'm going to show you something. I talked to you a little bit about the optic chiasm, and I want to show you just to give you an understanding of how maybe you really understand the neuroanatomy. This will be the corpus callosum. This is what we call a T1 image. So a T1 image is the one that looks most like the brain tissue itself. So anything that is white is going to be white. Air will be dark. So inside the ventricle, it's dark. What else do I want to show you? So you'll see, like here is going to be where the thalamus is. We're going to have the pons here, and then we'll make our way down to the medulla and the spinal cord. And essentially, what we're seeing is this is a T1 MRI on the left side and a T1 MRI on the right side. But what is true about this is they're using contrast dye on this side, and this is showing a tumor. So you can see where the tumor is and how it's putting pressure on the optic nerve. So that's a pituitary tumor. So we can get a bigger understanding of why somebody may be having visual problems such as this. And in your unit 2, you learned about neuroimaging with a T2 MRI. And in a T2 MRI, things will be reversed. So what is the ventricle on the previous side, the ventricles are dark, and we're going to have the gray surface on the outside. So this will be here, and then the lighter on the inside. So here, if we go to the opposite of that, we see that the ventricle is light. And where the cerebral cortex is, it's gray, it's white. So I know this is a T2 MRI. This is making it opposite. So remember I talked to you about the internal capsule. So internal capsule, corona radiata, where we have the white going up, it's dark. Okay? So here, let's see, here was our optic chiasm, back in here. So you kind of get the idea of what you're able to see. And in this case, this is another axial image, but what it's showing you is it's showing you where there's a bleed. So you can see the area here, either it's a bleed or a tumor, so it's a mass, and then these would be the ventricles. So think about what's happening to this lateral ventricle when it's compressed by a mass. So this is showing us through more or less a different metabolism of the brain when a certain dye is used, and it's showing us what can pass through in terms of the light, and it's going into showing us this mass here. If we move on, we have more slides, and again, these pictures come from your textbook, but what they're doing is they're showing you mapping of the brain. So basically, in this type of imaging, they're able to see when there's activity in the brain. So when the person is squeezing the ball with one hand versus squeezing or kicking their leg, we can see that real time that activity is going on. So what's important about this in terms of being able to visualize how the brain is working in each one of these different sections, so going from mid-sagittal to axial to this coronal picture, you can get an idea of what's going on during different activities. And when that happens, for me, I would love if we could have patients hooked up to that very easily, but it's not, we don't have that technology yet. But thinking about functional magnetic resonance and imaging one day will be, I'm sure, will be used in that capacity. And this is an angiogram. So with respect to the angiogram here, I was showing you how we have an anterior and a posterior blood supply. So here is the internal carotid artery, remember the big artery, and then we have our middle cerebral artery that goes back like this, and our anterior cerebral artery. If somebody has a stroke in the middle cerebral artery, they're more likely to have upper extremity and face paralysis, versus if they have a stroke in the area of the anterior cerebral artery, they would be more likely to have impairment with their lower extremity. And then the posterior cerebral artery, that's going to go back and provide the for the occipital region. And then we have our main basilar artery and our two vertebral arteries that joined into it. So hopefully those terms will be more familiar as you study more and more going forward. And then in the next 2 weeks, essentially, is where you're going to be, starting to really learn about the blood vessels that supply for the brain. So in terms of the evaluation, what we want to understand and what we want to think about, and we're not making diagnoses, but we can have a consideration into the situation with our parents, with our patients. So with respect to an examination, the first thing that we would be doing, especially in a hospital setting, is looking at the history of the patient. So how did the patient get to the hospital? If you're working on, say, subacute, in a subacute floor, or in a hospital, the first thing that's going to be recorded is what is the history. So what happened? How was the patient found? Or how did they come into the hospital? Did it happen quickly? So did whatever happened, was it a sudden stroke? And we want to know, is the pattern of progression. So from the time that it happened, what was the result from it? What did we think that happened at that point? So that again is going to lead to the examination. So, but one of the things that's really important to consider is mental status. So in typical neurologic evaluation, it's important neurologic screening. We want to find out, number one, is the patient oriented? First of all, are they conscious? Are they able to look at us in our eyes? If we ask them a question like, can you tell me your name? Can you tell me your date of birth? Can you tell me where you are? Can you tell me what time it is? Approximately what is the date? We're going to be using that as criteria to understand if we're able to take the evaluation further. And with respect to that, wherever you see the cases in the textbook, it's going to say, is the patient oriented times 3 or 4. 4 is, does the patient know why they're in a certain situation, in a certain hospital setting? So say for example, a patient was in a hospital, and it's made a determination that they need to go to a place where they can get rehabilitation. So they're going to go to a subacute care floor or a subacute care setting. So they may think when they're being discharged that they're going to be going home. They may be confused. So you go in to do the evaluation. Normally in subacute care, we have 24 hours to get an evaluation done from the time the patient gets there. So we're going to go in and do that evaluation. That patient may, when we go in the room, they might say, like, why am I even here? I thought I was going home, and have no understanding of what's happened to them. So understanding mental status, even for your national board exam, it's important to keep in mind that it's critical to understand what the mental status is, so we know if the patient is a reliable reporter, if we know they can follow our directions, are they able to have a short-term memory that will enable them to do what we ask them to do in the course of the evaluation. So always think about mental status as kind of like a prerequisite to doing the evaluation. So just like you do in your practicals or performance competencies, you introduce yourself, and then you see, you ask the patient to identify themselves. And essentially that's looking at mental status. The things that we evaluate what you're going to be learning in this course will be understanding about the somatosensory system. So is the patient able to feel, or do they have a disorder such as diabetes where they have peripheral neuropathy? Can they feel temperature? Can they feel pain? Can they feel if something is a vibration or proprioception, so position sense? So we learn about how to test those in this course. We learn about looking at the autonomic nervous system, what's going on with that in terms of sympathetic versus parasympathetic system, the motor response, so how our patient is able to actually go through, do they have a functional active range of motion? We know if they have a functional active range of motion in both upper extremities, then we can test the muscle tone. And then from there, we'll test the muscle strength. So that will be part of looking at the motor system. And then reflexes. Is the reflex brisk? Do they have presence of primitive reflexes that they shouldn't have? We'll also learn about testing cranial nerves. So the nerves going through 1 through 12. Interesting to think about cranial nerves when we have a deficit in a cranial nerve. In a cranial nerve, it's typically on the same side. So if there's a problem on a trigeminal nerve on the right side, then the disorder will be manifested on the right. So opposite, when we're looking at, excuse me, a central nervous system problem, like there's paralysis of the left caused by a stroke on the right. And then the last section of screening, we'll be looking at what's called gait and stance. So we'll be more with cerebellar problems. We get worried about patients' balance, and certainly many other things we worry about balance, but that'll be a component of what we consider when we plan our patients' ability to be independent with BADLs and IADLs. So when they're showing you this schematic, they're basically going through the thought process. Is it a peripheral injury or is it a central nervous system injury? Is it focal or diffuse? Focal meaning, say, something very specific like the middle cerebral artery. Or would it be more a multitude of problems that we might see in dementia or Parkinson's disease? And then thinking about the probable causes and the diagnosis. So essentially, when we take into consideration all of these components, that's part of how we do our evaluation as an occupational therapist. Does that make sense to you?
Yes.
Yeah. Okay. So I think now I'm just going to kind of go a little bit quickly through looking at the peripheral nervous system, and then we'll look at some of the areas. If you all are okay with that, we'll spend a little bit the rest of the time we have just kind of introducing you to the peripheral nervous system and then the cerebrum. So basically thinking of what the peripheral nervous system, it will be all the neural structures distal, so further away. from the spinal nerves. And at the point in which something becomes a peripheral nerve, we know that from we have an upper motor neuron, so that would be coming from the brain and going down to the anterior horn. And then from the anterior horn going out, that would be our spinal nerve, and then going to be servicing the myotome. So, and then axons of the cranial nerves, the cranial nerves themselves will be considered a peripheral nerve. So it's interesting to think about that. And then what else is in the peripheral nervous system? The axons of all sensory, motor, and autonomic neurons. So all of that information is going to be part of the peripheral system. What is part of the central nervous system is the brain and the spinal cord. So we can have different manifestations of problems when it's the central nervous system versus the peripheral nervous system. Some of the things that can happen are paralysis, sensory loss, abnormal sensation, atrophy, or difficulty with tendon reflexes. So we know that spinal region neurons will produce lesions in myotomal or dermatomal patterns. So when we think about this, our cranial nerves, so I'm going to bring you back to the cranial nerves. So looking at the cranial nerves, did anyone do this as part of anatomy?
Yeah, pretty briefly.
Pretty briefly. Would you be interested in me showing you the cranial nerves on the brain?
Yes.
Okay, so here we have olfactory, so cranial nerve number 1. And remember, these pictures are in your book, so you'll be able to study them. This is where the optic nerve is. So the optic nerve will go to the optic chiasm. So everything above here, not where the cross is, but from here, number 2 is going to be the optic nerve. And you have one for each eye. And then here you have cranial nerve number 3, and this is the oculomotor nerve. So here for vision, visual acuity, color, vision, this will be ocular motor, so motor control of our eyes. And then we have cranial nerve number 4, which is going to be trochlear nerve. So trochlear nerve is the only nerve that starts on the other side and comes around. And that's like almost like a strap, that nerve, because the way that it comes around. Here's cranial nerve number 6. I'm going to skip to that. So I'm going to show you 2, 3, 4, 6. 3, 4, and 6 are all your the nerves that are responsible for moving your eyeball. And then we have cranial nerve number 5. And this is the nerve you want, the portion of the nerve. Remember, it has 3 portions. And this is when I go to the dentist, I want to make sure that my cranial nerve is numb, my cranial nerve number 5, if I have to have a dental procedure. So cranial nerve number 5, it's interesting because it's going to be somatosensation. So it will be what we feel, something sharp in our mouth, something cold. So will be for a sensation as well as the muscles of chewing. Cranial nerve number 6, it's called abducens, and it abducts the eyeball. And then cranial nerve, so there's the 2 6s. Here's number 7. So cranial nerve number 7 will be the for our muscles of facial expression. So lifting our eyebrows up, making a smile, that will be cranial nerve number 7. And then go to cranial nerve number 8, vestibular cochlear, so for hearing and the vestibular system. And then cranial nerve number 9 is going to be glossopharyngeal nerve, and that's going to be assisting with swallowing. It also has gustatory taste, meaning that our taste, and that toward the back of our mouth, and that's more like, I think, associated with gag. So like something that is really like tastes horrible to you, it could make you gag. I think it's a protective function. And one other thing I forgot about 7, since I was thinking about taste, is that it's the anterior 2/3 of our tongue is for taste. I think that about my best example to remember 7 is think of licking an ice cream cone and smiling. So we're happy because we like the ice cream cone taste, and we use our tongue to lick the ice cream. And then we go to cranial nerve 10, which will be vagus nerve. And this nerve goes all the way down to the aortic arch. It's responsible for sensing like changes in pressure around the aorta, as well as some of the chemical components. So it will be like activity in the vagus nerve would be triggered if our oxygen is too low. We would have the sympathetic reaction to that. And then spinal accessory is here, shrugging our shoulders, turning our head, so sternocleidomastoid muscle. And then 12 will be hypoglossal, which is we hold out our tongue, and we see if it deviates from the left and the right side. So that's that. More in the peripheral nervous system will be our plexuses. So remember, in terms of, we have a cervical plexus, a brachial plexus, a sacral plexus, and a lumbar plexus. And remember that afferent axons coming from the plexus will go from the periphery to the central nervous system, and then efferent axons will be exiting from the brain. So think of exit from the brain with E, and afferent is ascending. That would work. I don't think I ever thought of that one before. We'll learn about different kinds of neuropathies. So a single neuropathy or multiple neuropathies or polyneuropathies. Here's a very common one, the stocking and glove syndrome that we can see with diabetes. You can see abnormalities that happen when there is peripheral nerve damage. So here we see either absence of sweating can happen. This is another type of nerve injury called Charcot-Marie-Tooth. You'll see this picture in your textbook, but essentially there's all different kinds of peripheral nerve injuries. Our class doesn't focus so much, but it helps you tie together what is peripheral and what is central. There will be tests that can measure the dysfunction of the peripheral nerve. So thinking about EMG, so recording the electrical activity. And we think about how in your modalities course, when you get to 4th term, you'll be learning about our electromodalities and how they're used in treatment. I think we're good with this one because we talked about these things. And then I just want to check in with you on time. So we have 10 more minutes. So I'm going to bump us all the way through here. And I'll just show you a little bit more about the cerebral spinal fluid. Would that be good? Do you want to see more neuroanatomy, or do you feel like you would like to ask questions? Anyone have any ideas?
I'm okay to move on to ventricles.
Okay, good. I think it's really interesting. So think about one of the most important things. So when we have some type of injury to the brain, remember it's up to 72 hours that the brain will swell. So when you think about the size of the brain and you think about the space for the ventricles, we know that if there is swelling, it's going to change the space of the ventricles. So ventricles themselves are spaces. So it's a hard concept to understand. It's not a structure, it's a space. So inside that space is where the cerebral spinal fluid is made. And here again, in these brain slices, we can, clearly see where the choroid plexus is. So thinking about if there's swelling of the brain, it will interfere. It can potentially interfere with how the cerebral spinal fluid is made and how it flows down and it goes into the central canal of the spinal cord. You saw the size and you could see like it's not really that big. So what does the cerebral spinal fluid do for us? It gives us protects the brain. It provides it hydration, amino acids, vitamins, some proteins that are neuromodulators, such as BDNF, which you'll learn about eventually. And then it can be helpful in removing things that should not be there. So this is the ventricular system. So when you look at the ventricular system, you can see up here where we had the frontal horn, and then we have our inferior or posterior horn, and then our inferior horn. This is the lateral ventricle itself. So you see that it's like, essentially, there's two lateral ventricles, right? So one for each side. But what will happen is it will flow through, this is called the interventricular foramen, and both of the lateral ventricles will give the cerebrospinal fluid to the third ventricle. And then from the third ventricle, it's going to travel down this skinny tube called the cerebral aqueduct into the fourth ventricle. So remember, that's the one that is the backwards 4. And then from there, it's going to go down a hole called the central canal into the spinal cord. So that's the structure of the ventricular system: 2 lateral ventricles, 1 third ventricle, and 1 fourth ventricle. From the lateral ventricles, it goes through foramen. So it's an opening, so the interventricular between the ventricles, the interventricular foramen, third ventricle, cerebral aqueduct to the fourth ventricle. And here you can see the flow. And it's interesting how it will go in different directions. So thinking about how it flows, it's going through, remember when I was telling you that it's going like in the layer or the space, that the cerebrospinal fluid is in the space that's in between the arachnoid and the pia mater. So the two of the closest layers of meninges that are to the brain, they have spaces, and in between the arachnoid and the pia, the subarachnoid space, is where this cerebrospinal fluid will flow. So what we know is that the cerebrospinal fluid does a lot of things, and you'll learn more when you get into this unit. But as mentioned, it's formed by the choroid plexus. It will circulate through the ventricles, and it will provide a number of functions, as we saw. Here we can see the fourth ventricle here, and up in here is where we can see the left lateral ventricle. So things that can happen to the cerebrospinal fluid system will be, we can have something called epidural and subdural hematomas. So below the dura mater and above the dura mater, you can have a bruising caused by trauma. You can have hydrocephalus. So hydrocephalus is where the cerebrospinal fluid is accumulating in the ventricles. Or you can have meningitis. I don't know if most people have heard of meningitis, but meningitis can be bacterial or viral, and it can be fatal. So that's something that causes swelling and infection of the meninges. That's where it's coming from. So things that can happen, there could be a failure of the fourth ventricle to open, so like a defect. And you can also have like cysts that can block. So imagine a cyst blocking the cerebral aqueduct, so it will cause that fluid to back up and not be able to go where it's supposed to be. And then meningitis and the different problems that can happen from that. So hydrocephalus will occur if the cerebrospinal fluid is blocked, and the pressure will fill up in the ventricles. And in this case, they will have to put in a shunt. They may have had to do a craniotomy, so they remove a piece of the skull, because the little baby's eyes are bulged out, because here's the frontal lobe, here's the excess fluid. And remember, you saw where the ocular motor nerve was, and you can get an idea, if they're swelling, what a horrible impact that can have. So here in this case, the child has hydrocephalus, when it's communicating, is going to allow fluid to go from one side to the other, or it's not going to. So here's what we see, you know, when we see dysfunction. And then I'll just show you a couple more pictures. This is the dura mater. So you see how the inside of the dura mater has like the piece that comes down and separates the cerebral hemispheres. That's what this is. So this is like the inside level of it. And then there's one more piece. So this thing is called false cerebri, and I call it faux, like faux leather. So here it is the false cerebri, and then here is tentorium cerebelli, and the tentorium cerebelli is the divider between the occipital lobe and the cerebellum. So I think the one thing I wanted to show you was back in here. There's a picture, and I think this is in like chapter 27 in your book, but this shows you what different lobes do. So what is the region? And then if there's a problem with that, what would be a result of the problem? So when it says primary motor, the region primary motor cortex, so affective lesion will be contralateral hemiplegia. That means hemiplegia is a paralysis. Hemiparesis is partial paralysis, hemiplegia is complete paralysis. And it would be contralateral, meaning that it's on the other side, because what goes on in the brain, in the primary motor cortex that cause hemiplegia will be on the opposite side of where the disorder is manifested. And then apraxia, and that's a loss of motor planning, difficulty with hand movements. And in the left side, we can have problems with Broca's aphasia, meaning the person has difficulty speaking. And then also, when the right side, the person has difficulty with understanding or performing nonverbal communication. And it's going, like, as you go through your textbook, come back to this chart and this one here, because this is a chart of layers, the primary motor cortex. And you can see number 2, this is where we're going to have motor planning. Each one of these areas are identified, and what it kind of helps you do is have an understanding of how different areas are associated with different function. So I'm just going to do one more slide, which should be our favorite slide. What I tell my students is their favorite slide is my reference slide. But when I post it, I'll make sure to put up the reference slide for you and eliminate the slides that we didn't do. So I don't know if anyone has any questions for me or comments. Was it TMI?
No, not at all.
Okay. Thank you. I hope not. I think it will help you when you go through and you study for your first exam to kind of like see how the information will build from the beginning anatomy, and you get more and more detailed understanding of what you're studying. Okay?
Yes,
Perfect.
thank you.
You're welcome. Take care. Have a good night, okay?
Thank you. You too. Thank you.
You too.
You're welcome. Bye-bye.